Very good morning, everyone. Welcome to 164th CMAAO weekly session. We are live on all the social media. We often go to our doctors and say our heartbeat is increasing. Is there any problem? I often go that. Um, so we talk about palpitation. I think this is our subject today, and it's a very important topic. We often have questions about it. So I request if anybody wants to join this session, I would like to open this session also. Whoever is live, they can come on Zoom meeting. They can join at 818-8591-1572. Anybody has a question, they can write in the chat box and we'll take it with the doctor. And to discuss about this, we have Dr. Vivek Chaturvedi. He's an highly experienced, acclaimed cardiologist with over 15 years of experience. He has served as a professor of cardiology in charge with arrhythmia and electrophysiology service in GB Pant Hospital. He is national authority in the field of electrophysiology, radio frequency attestation, and complex device implantation. He has over 50 publications in international journals and books. Sir, over to you.
Thank you so much. A very happy new year to everyone. And with your permission, I'll share my screen now.
Absolutely, sir.
Yeah. So, dear esteemed colleagues, one of the commonest, is my screen visible in the full presenter board now?
Absolutely, sir.
Yeah. So one of the commonest complaints that people have when they approach a doctor, whether it's an emergency or in an outpatient setting, is that of palpitations. This is one of the commonest symptoms for cardiovascular disease, and maybe even in healthy people. Today we'll just discuss some broad clinical aspects of palpitations, how to approach them, uh, which ones to be considered serious, to be either admitted or worked up for further etiology, and which ones you can reassure the patient and tell them that look, everything is fine. So with that, we begin. How common are palpitations? Well, they're very, very common. We all know that. We all, whether you're a general physician, you're an internist, or even if you're a surgeon, there are people who will come to you and says कि दिल में बहुत धड़कन होती है, which translated into means that I'm having a lot of palpitations or chest discomfort. So now the good thing is that the studies have found that almost a third of these are actually because of an anxiety or panic disorder. So anxiety or panic is a very common cause for feeling the palpitations. But then about, let us say 40% or so can be because of some serious cause. An important thing to remember here is that almost 1/10 are because of drugs or medications. So this may include over-the-counter medications like sympathomimetics, and there can also be, drug abuses or other substance abuses. This is an important but a missed cause for palpitation. So this history should often be elicited in these people. And then there can be other non-cardiac causes of palpitations as well. So what exactly is palpitation? So palpitation is just an awareness of your own heartbeat. This can be normal or it can be abnormal. It can be physiological or unphysiological. So when we have the typical, fight or flight kind of a mode, so either we are exerting or if we are very, very anxious or very stressed, often or even before exams, people say that they can often hear their heart beating. And so that is something which is entirely normal. And it's just because of increased sympathetic outflow and increased sensitivity of the brain. And so this is absolutely fine. Now, sometimes because this palpitation can be either because of a faster or abnormal heart rate, or it can be because of a higher volume of the heart, which is which is when contracting, it is causing an abnormal sensation in the chest. This can also happen with pregnancy, anemia, fever, or any other high flow situation. And so this is then it is abnormal, but a physiological. You can understand that in pregnancy the volume increases, so the heart size enlarges a little bit, and that causes the abnormal sensation. And then you can have abnormal, unphysiological situations for which several different mechanisms exist. These include cardiac mechanisms. They mean both electrical and mechanical problems. They can be vascular mechanisms and extra cardiac mechanisms, including thyroid, drugs, and other issues. So, how do we approach a patient with palpitations? Well, that depends on where the patient has come to you with the history of palpitation. So, if somebody presents to you in an emergency department with palpitation, then usually we have to consider them as serious. We have to obviously, first of all, look at simple airway breathing and circulation, look at the hemodynamics. And once you have seen that, then quickly we must do an ECG and take a focused history to rule out heart disease. So this focus history can mean just a history of previous heart disease and things like whether chest discomfort or shortness of breath or heart attack in the past. So these things, if we do this kind of thing, then we almost always will be able to triage these patients effectively in emergency department. What about outpatient? So in outpatient, obviously, when a person walks into you, the chances are that it could be either anxiety related or it could be something real. And so a more detailed history, examination, and ECG is required. And based on this, we subsequently decide which test need to be done further. The basic aim, as I said, in the triage is to differentiate between benign and serious causes and whether something is having a cardiac issue or not having a cardiac issue. Do remember that for most of these cases, the another factor which is very important in this whole equation is either whether you have a benign cause or you have a serious cause for palpitation. The overall prognosis for this palpitation and the treatment for this palpitation to a large extent is dependent on presence of or absence of structural heart disease. So, whenever we are assessing for palpitations, we must independently also assess for structural status. So that would mean whether there's any previous, heart disease or any damage to the heart, any heart failure. So this is something which is very, very important for the workup of arrhythmias and palpitation. And then, the aim would then further be whether somebody needs to be further referred for cardiac testing, or they can be simply reassured and sent back home. So in emergency, what kind of palpitations should be considered serious? So it's not always, in fact, it's a minority that a person who comes to emergency is having an ongoing arrhythmia which is causing palpitation. Most of the time somebody would say that I had this palpitation at home and by the time I reached to the emergency it had stopped. So then how do you really work up these patients in emergency to triage them? So some things are kind of a indicator that it can be a serious issue, and the most glaring history there is a history of syncope. So if somebody has a transient loss of consciousness which was reversible, then it is highly suggestive of a serious arrhythmia causing this, or a serious structural heart disease causing the palpitation and syncope. Again, as I said, a history of heart disease like myocardial infarction, history of valve replacement, being on cardiac drugs. So those are another important aspects in which you must take the palpitation seriously, even if they do not sound serious. But if somebody has a history of heart disease, you have to take them seriously. Then again, extremes of age. So children and elderly people, again, you have to take these palpitations seriously and consider them admitting, because often the causes are more sinister at the extremes of age group. And even though they may be benign in all both the age groups, obviously, but the probability of it being a serious cardiac issue are much more higher. Then obviously, if somebody has a low blood pressure or is cold, clammy skin, or you can auscultate a murmur, or if there's an abnormal ECG, even without ongoing arrhythmia, then these are signs that the palpitation is serious, and you must offer them triage down the actual cardiac pathway. So, what kind of history is important for these people? So, one thing obviously stands to reason. If 6 years, or somebody says that, I've been getting it since childhood, and the person is 40, might be an actual cardiac issue, but it is probably something benign because it's been there for a long time. And then, what kind of event was happening before the palpitation? So what kind of triggered this palpitation? So whether it was exertion, or whether it was, while sleeping or after a meal, or whether it was fever or stress. And then what happened during the palpitation? So how did it start? Was it gradual onset or a sudden onset? The sudden onset obviously suggests that this is a supraventricular tachycardia kind of thing. And then, how long did it last? Whether there was dizziness associated with that. So all these things should be elicited in the history. Also, in the background, we must, as I said before, find out how frequently they have been, whether this been progressive, history of heart disease, drugs, electrolytes, and a family history of sudden death. So this is especially true for channelopathies like long QT syndrome, etc., where sometimes the symptoms are very, very atypical, and because the heart function is normal, the ECG kind of looks normal in some people. So a lot of time these people are either treated as a psychological cause for palpitation and transient loss of consciousness, or they're actually put on anti-epileptics, which is obviously, the more the time passes by, the more you're subjecting them to the risk of sudden death. So a family history of sudden death is very important to elicit in these people. So this table briefly shows what kind of symptoms are associated with what type of arrhythmias. Important to remember that palpitations during exercise are mostly serious if they are real. So here, obviously, one has to differentiate between the usual palpitations somebody gets because of the exertion itself. But if they are very uncomfortable, so like a football player, he's been playing all his life, but suddenly if he says that I get such a bad palpitation that I have to stop suddenly and just sit down, then that is obviously something serious. So the history always has to be taken in the context of what had been happening and what is happening now. So that is obviously very important, because these arrhythmias, the ventricular arrhythmias, long QT syndrome, atrial fibrillation, these catecholaminergic polymorphic, these are all very serious diseases, and they are all brought on by exertion. So very important. Child comes to you saying that after playing gets very bad palpitations, which necessitates him to sit down. This is serious. You need to take it seriously. Uh, on the other hand, if somebody has multiple symptoms or there is panic, they are saying that I panic, then probably it's overall part of a very complex kind of a panic disorder kind of picture. So as I said, rate, regularity, termination, long duration, as I mentioned to you, there's a long history, past history is suggestive of PSVTs and PF. Now, this, if somebody has, as I mentioned, dizziness, pre-syncope or syncope, that is very, very serious. And remember this, that even if somebody has a normal heart, they can still have a non-sustained ventricular tachycardia, which causes dizziness. And this may not be having associated palpitations, but they just may feel very dizzy because the rate is so rapid that the onset of dizziness comes before the feeling of having palpitations. And then even with the simple PSVT, that is paroxysmal supraventricular tachycardia, if somebody has extremes of age, like and quite an old geriatric patient, or somebody has a compromised heart function, then even a simple AF can cause dizziness, pre-syncope or syncope. I won't go into the physical examination. Obviously, if you find something abnormal, that suggests that the palpitation has to be taken seriously. And then the ECG itself it gives a clue for many of the people, even when somebody is not in arrhythmia. So we get kind of telltale signs that there is something wrong with the heart in a sinus rhythm, although it may be fully normal in a lot of people. I suspect almost 50% of the people you would not find any clue. But if you do find an abnormal ECG, that's a good position to begin. As I mentioned, that anxiety is a very common reason for palpitations. Almost 1/3 of the patients with palpitations can have it because of anxiety or panic. Typically seen more in younger people. And then the clue to that is that there is a lot of somatization and emotional distress associated with this. By that, I mean that they would have multiple symptoms of multiple organs. So, somebody says, I have palpitations, and with that, I start feeling nauseous, or I start feeling as if I have to go and pass motion. Yes, it can sometimes happen that the autonomic system is activated with that. But along with that, if they also say that my left leg went numb, or I was having severe abdominal pain with that, then as the number of symptoms build up of different organs, you start thinking more of panic disorder than actual cardiovascular cause for palpitation. And a simple question like, have you ever experienced brief periods for seconds or minutes of an overwhelming panic or terror, which was accompanied by racing heartbeat, dizziness, or shortness of breath? Is usually able, if affirmative, usually points in the direction of anxiety as the cause for palpitation. But as I said before, and there are studies, study after study has shown that almost 15 to 20% of patients in the psychiatry OPD following up with anxiety actually have a paroxysmal supraventricular tachycardia. So, without ruling out other causes, one should never brand someone as just having an anxiety disorder. So, when to order other things? Well, if we suspect a structural heart disease in somebody because of the history, or if somebody already has heart disease, or if the palpitations are very, very arrhythmic as far as the history is concerned, then one must do an echo. And the reason is very simple. So I told you that palpitations, the risk stratification, it not just includes the frequency, intensity, and hemodynamic consequences of palpitation. It also includes the assessment of the underlying structural heart disease. And what better than an echocardiogram to briefly and screen for structural heart disease in these patients? But what about Holter? So Holter is something we see almost all of the people who have palpitations, they get a Holter done. Do remember that Holter or ambulatory electrocardiography is a time limited external recording of the ECG. And this may vary from a single day to 7 days. And there are people who are asked to wear it for 14, 15 days, which is a little bit cumbersome, although the miniaturization of external recording has helped in that sense. But it stands to reason that if somebody has, like, palpitations once in 3, 4 months, then obviously a Holter is not going to help you. And it's a unnecessary test in that context. The only place where even with infrequent symptoms, you need palpitation, and that too in people. Older people a lot of times have coexistent asymptomatic palpitation along with maybe infrequent symptomatic episodes of atrial fibrillation. So if you find asymptomatic AF in somebody who has palpitations for which we don't have the ECG available, then we can suspect that sometimes the heart rate, the ventricular rate goes up, and then that so the AF is the cause for palpitation. Because treat the palpitations or no, if somebody has AF and they have a high risk for thromboembolism, then anticoagulation is a must. So long-term monitoring, what are the commonest arrhythmias found? So thankfully, as I said, in about 30% patients, it will be just a sinus which is found. And 10% have cardia. About 25% have ectopics. So ectopics are a very, very common cause for palpitations. And here, I would just like to tell you about a brilliant study done, 3-4 years back, where people with a lot of high burden of ectopics with normal heart were followed up, and we all have seen such patients in our ambulatory settings. And the patient gets very vivid. They all are having pulse oximeters, and the problem with pulse oximeter is that like any other cardiac device, it measures the heart rate from beat to beat with every spontaneous beat. And the PVC is often not sensed by the oximeter in the periphery. And after that, a compensatory pause comes. So a very common finding recently, the visit for a very common complaint is nowadays is that even though they don't have any symptoms, the oximeter shows a very low pulse in the between, and they get panicked. So the commonest cause of that particular disorder is actually a VPC, and so you have to explain to them patiently what it is. So coming back to the study I was mentioning, this study actually showed that when you followed up these patients for 1 year, almost 30-40% the VPC subsided on their own. So you can obviously reassure the patients with a normal heart. There's a good enough chance that it might go away on its own. And then, about 15% have SVT, and then about 1% to have serious thing, and 10% have AF. So when do you refer somebody to a cardiologist or an electrophysiologist? Well, as I mentioned, if you have abnormal circumstances, serious with palpitations or an abnormal heart, then they do need a cardiac review. So if somebody has a history of syncope or transient loss of consciousness, have an abnormal ECG or an echo, there's a family history of sudden death, documented tachycardia is there, or if despite you're giving beta blockers or deltaism for arrhythmic palpitations, if they keep on recurring again and again, then this is serious and you must send them to a cardiologist. So some pitfalls you need to avoid, some myths, misconceptions in this. Not exactly related to our talk here today, but a lot of people assume that if somebody had a loss of consciousness with some incontinence or tonic-clonic movement, then it has to be a seizure. Well, that's not true. A syncope because of a serious arrhythmic cause like cardia or tachycardia, if it even sustains for, let us say, a minute, it can cause enough global hypoxia in the brain that you can have tonic-clonic movements or incontinence. The only thing which was found to be less as compared to syncope and fusion. The discriminatory capacity to differentiate between syncope and a seizure. Then again, one common misconception people have is that somebody who comes to emergency with serious palpitations but has ECG is normal, there is no tachycardia or bradycardia, then the person can be discharged. So that's not true again. You have to look carefully for the morphology of the different arrhythmic causes on the ECG and have to look for heart disease. If you don't have significant heart disease in the history on examination and the ECG is normal, so not just the rate, but the morphology is also normal, then probably the patient can be discharged. Otherwise, they can all have very, very serious causes. And nothing can be more true for this than somebody with long QT syndrome, where the ECG looks absolutely pristine, except that there is obviously QT is prolonged, but that is something which is often missed by people. Then, sometimes patients walk-ins who have had a heart attack or who have had a valve surgery and they have palpitations, but by the time they come to the emergency, they're absolutely fine. The blood pressure is fine, the pulse is fine. Well, the patient may not be fine. And I'm often reminded of a case where such a patient, and while on the way back home, the patient collapsed and never could make it back. Always better to keep cardiac patients with palpitations for a little bit of extended time in emergency because they do have high chance of recurrence of arrhythmias in the short term. Then somebody who comes to you walking into the emergency with a wide curious tachycardia, don't assume this to be an SVT just because it is hemodynamically stable. Many times the VT is also stable. And as I mentioned to you that somebody who's taking anxiolytics doesn't mean that definitely they have anxiety as a cause for their palpitations. So this is a flow chart. I would not go into the details of this flow chart, but as I mentioned that if somebody has unexplained palpitations, but if they are severe, then again you must subject them to further tests, which is obviously required. So just a brief overview now of the cardiac conduction system. I am sure all of you know it, but just for refreshing your concepts. So the impulse is made in the sinoatrial node, then through specialized fascicle, it reaches the AV node, from where through the His-Purkinje system, it kind of goes down the septum and the anterior wall into fascicles, which then arborize into conduction. These are kind of conduction super high to come down and go into the ventricles for near simultaneous activation of the whole. There is no other way for the electricity to come down except this specialized pathway. If you have other ways for the electricity to come down from atrium to ventricle, then that is called a accessory pathway. So one common reason in elderly people is atrial flutter. So this is a circuit that there is a circuit movement going on in the atrium, and then some of it, because this is so rapid, the AV node is decremental. It sends something down, but not all of them. And this can occur in the left atrium also, or in the right atrium. Right atrium is more common. Often it it looks like sinus tachycardia because it is conducted in 2:1 ratio. This is the typical sawtooth pattern where there is no isoelectric line in the ECG. You can see that there are no P waves, but this kind of a sawtooth pattern in the background with intermittent QRS. So this is a classical case of atrial flutter, but it may not always look like that. It may look like this, where it, unless you are very carefully looking at the ECG, you might feel that there are P waves and this is a sinus. But doing well to remember that these P waves apparently have no relation to the QRS. And again, there is this sawtooth pattern here, which is seen very clearly. And so this is an atrial flutter. Then another common tachycardia is a PSVT, where around the AV node there is a circus movement, and then this kind of activates both the atria and the ventricles simultaneously. The circuit is going on here, and then from here it goes back into the atrium and goes down to the ventricle at the same time. And this is called an AVNRT, and because the atria and the ventricle are getting simultaneously activated, so the P wave it's inverted because it's coming from below, but it is hidden or just hidden within the QRS, and it kind of distorts the terminal part of QRS sometime. So this is a typical ECG. There are some these are called the pseudo S waves in the inferior leads because of an inverted P wave at the end of QRS, and that also causes a pseudo R dash pattern in V1, which is very typical of AVNRT. So here again, you can see that the same person, this is the ECG. You can see that the QRS is fine here, and V1 has this small R and a large S and nothing. And the same person, you can see that there are deep S waves as compared to here, and there are R waves which are seen at the end of QRS. So this is a typical AVNRT. Then we have accessory pathway mediated tachycardia, in which the commonest one is the one in which it goes down the normal conduction system, and then it goes up into from the accessory pathway into the atrium, and this causes a circus movement tachycardia like this. Because it comes down the normal conduction system, it looks just exactly like the normal sinus ECG, except that the rate is higher. And if the pathway is capable of conduction both ways down and up, then it is called WPW, or Wolff-Parkinson-White syndrome, and then that causes a delta wave to appear, and which causes a slurred onset of QRS, which is wider, and you can have different kinds of WPW syndrome. An important point to remember about WPW syndrome is that if there is a very rapid tachycardia in the atrium, like atrial fibrillation or atrial flutter, which is the rate of 300 to 500 beats per minute, and this unlike the AV node, which has a braking mechanism, the pathway does not have a braking mechanism, and all of this fast come down from this pathway into the ventricle and cause VTVF. So somebody with an accessory pathway on ECG, like a Wolff-Parkinson-White syndrome, comes with a history of syncope. It is a very, very serious thing. So this, because atrium and the ventricle are getting activated in series, so it comes down here first, the ventricle gets activated, then the atrium, and then the ventricle again. So the P and QRS are not simultaneous. The P is buried inside the ST wave, so the ST segment gets depressed, and that is one sign of AVRT on the ECG. Again, you can see here in this patient, there is some QRS, delta wave, but mostly there's a short PR interval, which is one part of the syndrome of WPW. And then they get this very fast tachycardia. At some points, the rate is as high as 300 beats per minute. And so this is AF with fast ventricular rate because of a Wolff-Parkinson-White accessory fiber, commonly known as FBI tachycardia, which is fast, broad, irregular. This kind of a rhythm is a very serious rhythm. The moment you see this in the emergency, you need to give a shock to the patient. This is another has an ECG which looks a little bit wider, and although it's a little bit wider, we do know that it has it looks just like a left bundle branch block. So this is a left bundle branch block, and sometimes the supraventricular tachycardia can get an aberrant conduction and cause things like this. But this patient presented with syncope and shock to the emergency, and she was cardioverted, which is the right thing to do. Even if you suspect this patient to have a supraventricular tachycardia, if somebody is having hemodynamic compromise and you think this could be a VT, then you have to shock this patient. There is no two doubts about it. And this patient actually then, when she shocked her, then we could see that there is a delta wave, and she was subsequently ablated, and she had a left-sided pathway. Now, if you get atrial ectopic, so like, normal ectopic, normal ectopic. This ectopic, it looks just like the sinus rhythm, but the preceding P wave has a little bit of an abnormal, morphology than here again. So these ectopics then are a clue that the palpitations can be because of an atrial tachycardia or atrial fibrillation. So this is a kind of a sinus rhythm clue to the history of somebody who comes to you after the episode. Again, in some people, you get this kind of a fragmented P wave. You can see that there are two humps in the P wave. And this is often seen in elderly people who have AF because the atria are enlarged, they are scarred, the conduction through them is slow. So overall, the P wave becomes very fragmented and slow. So this is another clue that the palpitation is because of an atrial fibrillation or atrial tachycardia. And obviously, we do know that this is AF. We all know AF, that this is, it's completely irregular and there are no P waves seen. Sometimes we can get confused. So this boy came with the incessant tachycardia. You can see that the RR interval is equal to 2 large squares. So it automatically makes it 150 beats per minute. And if you don't pay attention, we would think this is sinus because in lead V1, we see a P wave always coming before QRS. Except that, why should somebody have a heart rate of 150 while sitting down? And then if you look carefully, then this looks almost like this T wave here. So this is not just a T wave, this is a superimposed P wave. And this is, so there are two P waves for each QRS, and this was a atrial tachycardia. So if you have this kind of a picture where somebody has come to you with some history of palpitation, and they are, when they come to you, they have something which looks like sinus, but the rate is higher. So then you must start thinking that if this person is fine, there is no anemia, there is no thyroid problem, there is no obvious structural heart disease, why should somebody who is sitting down in front of you have a heart rate of 150? And then that makes you think that this is not sinus at all, then this is something more. And what happens is that AV node is heavily influenced by the autonomic influences. So right now, when the person comes to you is sitting down easily, the heart rate, the ventricular rate is 150, and there is 2:1 conduction of this thing because there is some vagal influence on the AV node. But under stress or under sympathetic outflow increase, the AV node can start conducting faster, and this can become 1:1 tachycardia, in which case the heart rate will go up to 300. And that's when the palpitations will happen. So always you have to think of the context and the physiological situation in which you're seeing the patient and compare it to the ECG. And so this is another here that somebody who's come to you again, the person had palpitations, and you can see that this is obviously P to QRS. The clue here was that the P wave is, so this is quite peaked P waves here, and look at lead V1, which actually has a biphasic in sinus P wave, but there are tall peaked P waves here. This person, if suddenly has stress, the atrial focus will start firing more rapidly, and the palpitations will start happening at that point. So atrial tachycardia, you can easily demonstrate in most of the patients by showing AV dissociation. So what you do is like this patient in which whom I did, this looks like somebody with tachycardia. Again, this patient came in sitting down with me and saying, I get often on palpitations on walking. And it looks like this is a sinus tachycardia. So you can see P waves here very clearly. But then beyond, just before the P waves is all very, very blurry. So you somehow increase the vagal tone and see if it dissociates the atria from the ventricle. One very common maneuver after you've ruled out any history of stroke is to do a carotid massage, or you can give adenosine. And once you do that, then you can see that because of the vagal influence, the ventricular rate has gone down because AV node is now super restrictive, and P waves are continuing like this. So this was a atrial flutter. You can see the sawtooth pattern now with variable conduction rate. Another point to remember is although this is not so important in our talk today, is to carefully look at the ECG, even if you can't find something, but if you find AV dissociation. So classically, we look for this in lead 2, and you can see that nothing is seen very clearly, but in between you can see these P waves here, here, and that kind of tells you that the QRS is RR rate is more than PP rate, and that kind of suggests that this is a ventricular tachycardia. Again, in lead V1 is a good lead to see for P waves, and you can see this, but suddenly there's a hump here, which is suggesting a P wave. Then another important uncommon causes, and this is especially important because a lot of videos are going on viral nowadays of dandiya players suddenly collapsing and other people also collapsing while playing in some drama or things like those. So one very common cause for ventricular tachycardia, I would not say very common, but common in the sense of sudden deaths that happen in young people. Very common cause is arrhythmogenic right ventricular dysplasia or ARVC, and that causes a very terrible kind of a VT, which is responsible for exercise-related sudden death. So a lot of people, like footballers, you see collapsing on the have hypertrophic cardiomyopathy or ARVC. A characteristic feature here is this is a classical ECG of somebody with ARVC. You would see that overall the voltage complexes are low, and then there is a kind of an RBB pattern here, and then there's a notch at the end of QRS, and this notch is called the epsilon wave, and this is a pathognomonic sign for ARVC. This is another one where you can see typical right bundle kind of pattern, and then there is a notch at the end of QRS here, and this is ARVC. So this is another ECG from a young woman who had absolutely normal heart, kept on collapsing, and you can see that tachycardia happens. It's all bizarre kind of tachycardia. Sometimes couplets come, sometimes more, and this is something called torsades, and the background ECG is this. So offhand, somebody would pass it off as normal, and this person comes to you with syncope, history of syncope to the emergency, and says that I'm fine now, but I had a syncope and I've been having it for the last 15 days. You may pass it off as normal, but actually this is not normal. If you have to look carefully, as I mentioned, to the morphology, look at the ST and the T wave almost reaching till the P wave, which is very classical of QT interval, that it occupies more than half of the RR interval. Not only that, if you see here, then this looks different from this, and this kind of alternates on every beat. So the QT interval and the size of the T waves are varying on every alternate beat. This is called QT alternance, which is a malignant sign of for suggesting that of risk of SCD in these people. So long QT syndrome, super important to remember in context of palpitations followed by syncope in younger kids, as well as in young adults, especially women, typically even after pregnancy also, or after exertion, if somebody gets palpitations and syncope. Also, sometimes in old people, if they have underlying bundle branch block, so like this person has a right bundle branch block, the PR interval is prolonged, and there is a left axis deviation or a trifascicular block. This by and large, it means that the conduction system is having problems. A lot of old people actually also say palpitations when they are having bradycardia, because the heart feels abnormal to them. Not only that, if this kind of patient comes to you with a history of syncope, it may not be just because of bradycardia. It can be also because the severe bradycardia also makes you prone to tachycardia, which is even more, which is usually the cause for SCD in these people. So, as I said, abnormal ECG is very important in the context of triaging a patient with palpitation. And then the commonest cause, as I mentioned to you, is PVC. So if you see extra beats in the heart, then that is highly suggestive that this might be the cause for palpitations. Another important cause in young people is hypertrophic cardiomyopathy, and they can have multiple causes for their palpitations. It can be atrial fibrillation, which is very common in these people, and as well as ventricular ectopics and ventricular tachycardia. You can see large voltages here and deep T wave inversions here, and so this, as I again and again, I'm harping on the same point that when you say that the ECG is normal, you have to look not just at the rate and the rhythm, but you also have to look at the morphology. So this person is perfectly capable of having a spontaneous VT from which he recovers by the time he comes to you. But once he has a VT, there is a good enough chance that the VT will recur in the next 24 hours. So you have to, offer prolonged monitoring to this kind of a person inside the hospital. Another common cause down south India and in Far East, and I believe we have an international audience today, is syndrome, where you get more of syncope, and they would never have trivial palpitations. All these people with long QT syndrome, with Brugada, they would always have palpitations which are followed by pre-syncope or syncope, because these are ventricular causes for. You have this kind of a right middle branch block pattern, which is having an ST elevation in V1, V2. This is very typical of Brugada syndrome. Again, a very, very serious problem, and one should always obviously need to offer them an ICD. And then something which can have a totally normal ECG and a totally normal an echocardiogram and all kinds of workup. But the classical history is that of exercise-related palpitations, more common in children, but sometimes you see in an adult. And this is one such case where when we subjected him to to a Holter while he was walking, you can start seeing that there are bidirectional complexes. So sometimes the PVC is going down, sometimes it's going up. So this is very classical of CPVT, or catecholaminergic polymorphic ventricular tachycardia, and the treatment for them is beta blockers. As I mentioned to you, never make the mistake of thinking that somebody with a wide QRS tachycardia who comes to you has, and if he's walking in, then everything is normal. This has to be supraventricular. So this is one patient who had extensive anterior wall MI, and he said that I'm having palpitations. This was his ECG from previous visit. So when we ordered the next ECG, it looked like this. So the rate is not very high, and my resident initially diagnosed this as sinus tachycardia, but clearly you can see that there are no clear-cut P waves preceding each QRS. And then, as I mentioned to you in a previous slide, you can see telltale P waves coming in between many more frequent QRS. So this was a stable monomorphic VT. Important to know is that this stable VT can suddenly become unstable, and as the rate picks up. So again, they always need admission for this. So with that, I would like to close and take any questions. Thank you for your patient listening.
Thank you, Dr. Vivek Chaturvedi. This is a very detailed session. Dr. Monica, would you like to take the session forward?
Sure. Thank you so much, Saurabh. Thank you, CMAAO, again. And thank you, Dr. Chaturvedi, for a fantastic presentation. It's always good for those of us who don't know PHEs to have the wonderful summary that you provided us. It's always a good review. The question that I have for your presentation is, we're in a new world of wearable technology. And so with Fitbits and Apple Watches and all these wearable monitoring devices, how do you see the approach to diagnosing and managing palpitations evolving in this environment where you have people who are now bringing to you, I now have this app that shows me that my heart rate is ranging from this to this. And I think now you're dealing with a lot more data than I'm feeling palpitations. And how do you feel that this, the second part of this question is how do you feel that the technology-driven diagnostics is going to aid your traditional clinical assessment?
Yeah, so that's a wonderful question and a wonderful reminder of this fantastic technological innovations that we are actually living on with now. In a lot of ways, wearable technology has made my task a lot easy because especially when you have PSVTs, that is paroxysmal supraventricular tachycardia, and you have episodes occurring, especially in young people, like once in 6 months. Now, what kind of monitoring can I offer to them? It's very difficult. And so we always used to write ECG, but many times these episodes would last only for like a couple of minutes. So before you get to the hospital or a clinic, the tachycardia is gone. So those are the kind of people in whom I find that an Apple Watch, is a real very very helpful thing, because while I may not be able to get the exact etiology from that, but the rate of tachycardia is very very informative to me. Most of these people, I usually tell them that if the heart rate while you're sitting down is exceeding 150 for a typical young person, then probably it is abnormal and needs further evaluation by me. Needless to say that it has also made my task a lot difficult, because with the panic of cardiac problems during COVID now, you get all kinds of transmission to my social media handles of of ECGs generated, which are purely simple sinus tachycardia because a person is having heightened anxiety. But by and large, what I found useful is once I've evaluated them structurally wise, that they have a normal echo and their ECG at baseline is perfectly normal. I find it nice to explain to them in detail that even if they have some tachycardia, that's fine. We will take care of it, but they need not panic about it because it's not going to have any long-term consequences to their life or their heart.
I have one more question, and that is, what is the advice that you would give to somebody with a low voltage EKG?
So the low voltage EKG is something which can be fairly specific, fairly accurate to diagnose few things. So it has a high sensitivity, but a very poor specificity really, in the sense that if you would recollect your basic ECG thing, we're recording the electrical activity of the heart, but at the skin surface. So the lung volumes, the chest wall thickness are very, very important determinants of the voltage that you get on the outside. So keeping those in mind, certain things in the heart are, the classical things which we are taught which cause low voltage are things like large pericardial effusion or severe hypothyroidism or amyloidosis. And the clinical context, as I said, is very, very important. So somebody who's perfectly normal, has no complaints, comes to me and who's obese, low voltages are absolutely fine with me. But similar low voltage with mild aortic stenosis and LVH on the echocardiogram and has some severe puffing, I know that this is amyloid. Or somebody who has fever, having night sweats, shortness of breath, a typical young male from South Asia, has severely has cardiomegaly on the ECG, on the chest X-ray, and then has these low voltages. I start thinking of pericardial effusion.
Got it. Thank you.
Right.
Nidhi, would you like to go forward?
Excellent presentation, Dr. Vivek, and I think you've touched upon the few things that are causing anxiety in the younger people these days. Two parts to my question. One is it really that it is just anxiety, or there is a real rise in cardiac problems in the younger age group, say between 20 to 40, 45? And secondly, what is the one thing that you would advise that people should start doing on a regular basis for a healthier heart? Non-dietary.
Yeah. So yes. So the first part of your question was about. Can you just repeat the first part?
Yeah, I said, is it really just anxiety, or
Yes.
is there a real
Yeah.
rise in cardiac problems
Yes.
in the younger age
So,
group?
so there are, if you can permit me a detailed explanation for this, there are two things to it. So I've been tracking heart disease in young for a long time now. Uh, definitely, there is some element that these episodes used to happen earlier also, but because of the CCTVs and the constant barrage of social media that we have now, that they are being brought more to the attention of people now. It's not that we didn't have sudden deaths in young people earlier. We, in fact, way back in 2012, you would be surprised that I alone in my sitting in my outpatients, just one consultant, over a period of 2 years, we could collect 100 patients with heart attacks between the age of 20 and 30 from one hospital in Delhi, just one person. So you can imagine it's never been really that uncommon. But for sure, the acquisition of adverse lifestyle that we are seeing now in younger people with rising incidence of substance abuse, also rising use of unsubstantiated and dangerous naturopathy and to some extent Ayurvedic products without any supervision. Uh, this has increased stress and to some extent also COVID, because cardiovascular outcomes in long COVID have also been quite bad. So these things over cardiovascular problems amongst younger people also. I would not, earlier we would say that somebody below 30 comes with chest pain, okay, nothing's not going to be hard. I can't say that insurance to anybody anymore. As far as one single intervention to everybody who has, for keeping a healthier heart besides diet, I would say one is to go out and exert yourself. Uh, so yes, I did mention that some arrhythmias are brought on by exertion, but there are two things which exercise does to you. One is it makes your heart stronger in every which way. So whenever you, so like somebody who is going to have heart coronary artery disease, if their heart muscles become stronger, the exercise makes them more collateralized. They can tolerate a heart attack or an acute event much better. So it makes your heart literally stronger. That is one thing. The other thing is that a lot of cardiovascular illnesses, not just arrhythmias, but CAD or heart failure, the first symptoms come on exertion. But if you're not exerting, how would you come to know? So, and with the sedentary lifestyle that we have today, stop exerting. You have to exert physically to know how heart is. So that way is also, so as a therapeutic tool and as a diagnostic tool, I think exertion, physical activity is very, very important advice I would like to give to youngers.
A very good point you've made. And that is what I wanted to bring out, because people often think that exercise is contraindicated in a cardiac patient. But I have evidence from my own family. So if I could, my grandfather had a left bundle branch block, and my father has he's 85 now. Over the last few years, he was complaining of a little bit of problem with heart rate. And when he was investigated, he was found to have such good collateral circulation that he was told he needn't worry because he's an exerciser.
Excellent. Yes, that's right.
So this is what I think this cannot be overemphasized, that
Yes.
it's not just for fitness but for health,
Correct.
that there is a minimum daily requirement.
Yes.
Thank you so much. Thank you.
You're welcome. You're welcome.
Then do you have any suggestion for old age people who don't have any problem, probably just a mild blood pressure, but any precautionary medication which we always hear in the videos and everything, like a blood thinner or a statin or something, just to start as a routine to save yourself, something like that, for unexpected incidents, like people
So,
above 60.
yeah. So one thing is that the definition of old age is changing now. Do remember that all medicines that you have today all of them, there is no exception to this. They cause more problems in elderly than in younger people. The expected and unexpected side effects are much more. So in truly older people, and my definition would then, would be something beyond 75 really, not 60. 60 is not old anymore. So beyond 75, I would not treat them prophylactically with any drug for that matter. I would have a very high threshold for giving them any drug. If required, yes. Otherwise, no. And this is especially true because a lot of people get prophylactic aspirin beyond the age of 75, and it's been known to cause a lot of GI bleeds. So unless one has concrete proof, one should not start these medicines. Obviously, somebody who is beyond 75 who has just hypertension, I wouldn't start it. But somebody who has diabetes, who is a smoker, and he has hypertension, probably I would, in a male, I would probably start aspirin and a statin. So clinical context, but as a blanket, I would not say any treatment deserves or is that good that it can be started as a blanket therapy in elderly people.
And for young generation, people who are into fitness and everything, like we have seen a lot of heart attacks and a lot of issues during the treadmill. We have seen a lot of, like Raju Shrivastava was one of the guy who lost his life during the treadmill, and similarly a lot of people doing that. So there's a fear of using the treadmill. There is a myth saying that if you do a workout, I understand that if you're doing a certain workout, it's a problem, you should go slow. But what is your suggestion, and what is the highest heartbeat people should go for, and what is the cooling period of the heartbeat?
Yes. So one thing is very clear, that somehow because of increasing, uptake of bad risk factors as well as genetic tendency, Indians do have a high risk of heart disease at a younger population. That is an undeniable fact. Genes have a significant role to play in that, and we have to just accept it because we can't change it. So my advice to most of the people is that, if you have risk factors for heart disease, and broadly they include things like diabetes, high blood pressure, smoking, obesity, high cholesterol, very important, family history of heart disease, especially premature. Premature would, in my context, would mean something like below 40, 45 for males and 55 for females. So if you have these risk factors, then before you go on to a vigorous exercise program, you must consult a physician and probably undergo supervised treadmill test just to look at your condition. So that is very, very important. And that brings us to the thing that actually we must need to screen almost all of our population beyond the age of 30 years for things like blood pressure, diabetes, and cholesterol. This is very important. We get 200 tests in all the wellness packages nowadays. All that is not needed. All you need is simple glucose, cholesterol, and blood pressure, probably BMI for everybody above the age of 30. Once somebody has started this exercise program, then again, too much, too soon, too fast is something which is quite bad because we are not adapted to it. Do remember that during intense period of aerobic activity or during intense resistance periods, the blood pressure can rise to almost 300 millimeters of mercury. And that puts a tremendous load on the heart. If your heart is not prepared for it, it's going to collapse. There is no two things about it. So very important, we go on and gradually build it up. This is especially true for people above the age of 40, because nowadays in India, we see a lot of people who have toiled their way through the youth. And after the age of 40, now they've got enough, resources to actually, indulge in physical activity. And so now they want to suddenly become marathoners and, elite weightlifters when they have actually been sedentary their whole lives. This just doesn't happen because you've lost that bus. You can still go as high as it's possible, but it has to be in a supervised, gradual manner. So that is the thing. The other thing is that proper hydration is very important during these exercises. You need to listen to your body. Again, supplements are a big controversy in India because a lot of them are actually contaminated, and purposefully people take other mixed supplements which have steroids, which are again very bad. We all know about that. Coming to the last point about the heart rates, usually I would say that the maximum heart rate we all know is 220 minus age, but practically above the age of 30 years, I would say that if you are going in any exercise, it should be about 70 to 80% of that particular amount. So like somebody who's 40-year-old, so his should be 180, but it should not go above 160 or so. That is 75% of 180. So that is what I would tell almost everybody, that and there is a lot of data now that this at least in the beginning, this zone 2 to zone 3 training, and then gradually increasing your heart rate to higher zones is what is advisable now. Otherwise, you should not indulge in vigorous activity if you are not prepared your body for it.
Thank you so much. Very well answered. Do we have any other questions on the floor? I think we have over time now. So with the respect of the speaker's schedule, we would like to end the session if there are no more questions.
Thank you so much.
Thank you, Dr. Vivek, for very good session.
I wrote in the chat.
Dr. Manisha, just go ahead and ask the question quickly.
Okay. I wanted to know, I'm seeing a lot of candidates on normal people for aviation. So normal complexes, they're asymptomatic, but rate is arrhythmia in young. So on repeat ECGs, often they come out normal.
Yeah. So by
And
arrhythmia, you mean
done, if do I need to only repeat the ECG in different machine, or do I go for cardiology and echo and further tests?
so things like aviation fitness or a locomotor pilot, these are high risk jobs. If you find an ECG which is abnormal, you must send the person to a cardiologist for proper evaluation. When you say arrhythmia, then I'm thinking that you're meaning more of high heart rate or low heart rate, or some sinus arrhythmia, because obviously if there is a
No,
very
just
ghostly
simply the complexes are all normal. Like in respiration, we have changes.
sinus arrhythmia. Yeah. So sinus arrhythmia is something which is very, very common. It's something not to be, the heart rate cyclically changes along with inspiration and expiration. So by and large, it doesn't need any medication. It doesn't need any further investigation at all. But if you're not sure of the diagnosis of sinus arrhythmia, then it's better to do a Holter, and that could actually clarify these things.
Hmm. So they are younger experiencing this often, teenagers and
No,
young adults.
yes, it's very common in younger age group, also in not just in teenagers but in youths. So somebody who's come to for you for fitness pilot is essentially likely to be having higher physical capacity, and people who are athletes have something called vagal tone, which not only decreases the heart rate, it also makes sinus arrhythmias more prominent.
Okay.
Yeah.
So, but offhand, we just can't dismiss it. May repeat the ECG many times and repeat ECG, I'm getting wrong. So, if that should be acceptable. Otherwise, we refer to cardiology.
Yeah.
Okay.
Yeah.
Thank you.
All right. Thank you so
Okay.
much. Thanks.
Thank you so much, Dr. Vivek Chaturvedi. This is an excellent presentation, and I think we would like to invite you for a follow-up session anytime soon. Thank you so much for joining in.
Thank you so much.
Thank you, everyone, for joining.